Hello, it's Dr. Carr. I'm talking to you from my office today. It's a great day, and I want to give you a little bit of background. This video is going to be more about one of the more common questions that I get asked. Now, remember, I practice hormonal medicine in Rancho Mirage, California. I've been doing this for many years. I've been here about 18 years in California. I had a similar practice on the East Coast, so it's well over 24 or 5 years that I've been practicing mostly just with hormones. So I would say one of the most common questions I'm asked is, if hormones are so safe and they're so effective, then why isn't my doctor on board? Why isn't my doctor advocating for hormones? In fact, why is my doctor saying they're going to give me breast cancer, or in a man prostate cancer, or they're just no good for me? There are many answers to that, but I'm going to break it down into two things today. Now remember, I'm a traditionally trained MD. I did my undergrad in medical school at the University of Miami in Florida. Finished medical school in 1987, then went to Cornell in New York to do my residency training in internal medicine. So I've gone through traditional medical training is the point, right? Unfortunately, the way doctors are taught in medical school and training, residency training, is not very different today than it was back when I started in 1983. Here's what I mean by that. The first 2 years of medical school, it's mostly classroom didactic learning, right? You're learning fantastic stuff. I love the first 2 years of my med school. I could not get enough of this information. Then the third year of medical school, you start doing your clinicals in the hospital. That's when you start getting different, you get exposed to different specialties, OBGYN, surgery, internal medicine, etc. And we'll go through these some more over time, but here's the point I want to make. When you're finished in medical school, you have to make a decision going into residency training. And in my opinion, there's literally a fork in the road. Are you going to go into a medical subspecialty, which I'll define in a minute, or a surgical subspecialty, right? So what's a surgical? Well, general surgery is a surgical subspecialty, neurosurgery, cardiovascular surgery. Those types of things, doctors in their residency training will learn, spend most of the time learning different surgical techniques. And thank God they do, right? Anybody that's had surgery, I've had several surgeries, different things. I mean, say what you want about a medical system, but when we have an urgent or emergent matter that needs surgery, there's no better place in the world to be than in this country. We have those highly trained surgeons anywhere. I wouldn't be here if it wasn't for my surgeon in San Diego. So I want to make sure that's clear, because what I'm talking about with hormones is not antithetical to what traditional medicine has taught to treat disease. Going back to the model with the fork in the road, though, the other specialty pathway is medical subspecialty, internal medicine, cardiovascular medicine where you're not doing surgery, pediatrics, etc. So let me start with kind of a sub-question is, not only do people ask me, why is my doctor not on board, but why is my gynecologist not on board? I mean, they know women's parts, etc., with women's hormones especially. I would say, again, as a general statement, that in my experience of doing this about 2.5 decades, gynecologists are the least informed as a group and the least ready to accept the benefits of hormone therapy. Why is that? Well, when there's that fork in the road, gynecology is a surgical subspecialty. I was very close to going into gynecology when I was graduating from medical school. I had a spot for residency spot, etc. I loved that I thought, I could do women's health in a clinic and surgery, etc. I got a little bit discouraged, I guess I'd say, when I saw how many hysterectomies were going on. This is in the 1980s. And I thought a lot of them were unnecessary. But the point the point I'm trying to make for this topic is, gynecologists in their training, they're being trained how to do surgeries. And again, thank God they are being trained for that, because if a woman's had a complicated birth process, she wants a good surgeon. In that moment, it doesn't matter what her doctor knows about hormones. That's not what's important. It's important that they save her life with an emergency C-section or whatever's necessary. hysterectomies, whatever it is, that's how they're trained. So when a gynecologist in general says that a person doesn't need bioidentical hormones, I want to be specific about that, they usually are saying that because they really don't know. They haven't had the training and experience. So that's one major reason why most doctors are not on board. They simply don't know, and they've gone into either medical or surgical subspecialties. To this day, 42 years after I started medical school, to my knowledge, there's been no major change in the curriculum. That is, I don't know of any major medical schools teaching bioidentical hormone therapy. Now, I know that's not in some perhaps DO schools and naturopathic schools they are. But again, I'm talking about allopathic MD trained doctors are not being trained in bioidentical hormone therapy. Okay? The second reason is, and this is a big one, to be honest with you, and again, it's not bashing people or our system, but in case you haven't noticed, when you go to your doctor, the doctor has to put a reason for your visit. They have to put down what's called an ICD code, International Classification of Disease. That's how they get reimbursed for the visit. That's how everything's followed. That's what the insurance companies will pay for. They will pay limited amounts for sure, based on the ICD. I think we're up to IC-10 code. I think we're up to version 10. I don't bill insurances anymore, so I don't know. But the bottom line is most doctors' billing and therefore practice and therefore knowledge is based on treating disease. Has a woman listened to this ever gone to the gynecologist for her well woman exam, say for a pap smear? And she might say, by the way, doc, besides, what I'm here for today, I wonder if you could look at XYZ, which is hurting, or this or that. Some doctors will look at it on the spot, but a lot of doctors will say you have to make another appointment for that. Why? Well, because they can't really put that into the paradigm of what they're billing for that visit, okay? So the reimbursement system is set up to pay doctors who put down a disease code. I'm dealing mostly in aspects of aging. When a man's testosterone level is decreasing, that's part of aging. It happens universally. Just about every man over time, maybe at different ages it starts going down, but every man over time, the testosterone is going down. Every woman over time, estrogen is going to go down and then have menopause and go down steeply. Progesterone, but not just the so-called sex hormones. Adrenal hormones like DHEA, for most people, men and women alike, peak in their 20s. Growth hormone, very important hormone I'll talk about more in the future, peaks in the 20s. They're going down because of age. So think of it for a minute from the insurance company's perspective. They're thinking, wait, we're here to pay for diseases and surgery, etc. Now you want to pay for the equivalent of gray hair. That's how they look at it. Remember the insurance company's model. Their model is not to pay to take care of people, and let's be honest about it. And again, not villainizing them. They paid a lot of money when I had a very important surgery, okay, for my care. But their model is collect premiums, pay out what they have to, but don't pay out what they don't have to. So if they can look at something as an aspect of aging, and for a lot of these hormone deficiencies, not all, for example, thyroid problems can happen, at any age really, but even in the 20s and 30s, that's when mine failed in my 30s from an autoimmune process. But that's more in the disease realm. My doctor back then diagnosed it as autoimmune Hashimoto's hypothyroidism. Disease code, everybody's happy, they get billed, the insurance pays a certain amount. But when we're talking about hormones that go down with age, number one, the doctors don't know much about that because, to my knowledge, again, it's not taught in MD med schools to this day. It's not taught in training. And then the other problem is doctors have lumped hormone therapy into one big group, and they don't separate out bioidentical hormone therapy, which is the only type of hormones I'll treat. And why is that, by the way? Well, it's real simple, right? You could ask a third grader, should I give daddy or mommy mommy hormones when hers get low, or, for example, horse hormones, which is what Premarin comes from, horse urine? I mean, a third grader could answer that question, right? So it's not really a mystery. It's just that our system is set up and promoted for commercials from pharmaceutical companies promoting their product. Again, no harm, no foul. They get to promote their product. I don't have any issue with that. I do have an issue with doctors who don't say, geez, you're asking me about hormones? I don't know. I do hysterectomies, or I deliver babies, or I do ankle surgery. If you ask me what the best type of stent for cardiovascular disease is, I'm going to say I don't know. But let's find the right doctor to answer that. Well, too often people are being asked, doctors are being asked, what about being on estrogen when I'm approaching menopause? And rather than doctors saying, I don't know, they'll say, oh, no, hormones are bad for you. And I'll tell you why. It goes back to a study called the Women's Health Initiative. If you want to get ahead of yourself, just type in WHI. That study was seemingly complex, but the problem is they studied the effects of Premarin and Prempro, which come from horses, on women's health. Well, again, we could ask a third grader, like we just did as an example before, is that going to be good for mommy long term? The answer is no. We knew there were going to be problems with that. I never prescribed that stuff. Even before hormones became fashionable, I was using bioidentical hormones. Bioidentical hormones have to be, by definition, the same structure, 100% as what's in the human body. Okay? So that's why it's not, you don't see commercials about it on television. There's no patent that can be taken out on testosterone or estradiol any more than you can take a patent out on water. All right? It's part of nature. So there's no incentive. There's no incentive for the pharmaceutical companies to make these hormones and produce and promote them. There's no incentive for doctors, and there's a big knowledge gap, quite frankly. I am disappointed. When I started this over 2.5 decades ago, I thought there'd be a lot more doctors informed about hormones than there are now, but they aren't. They're saturated. They're busy with their own practices, right? But again, they should at least know, even for their own sake, because who needs hormones over time? Everyone. Not everybody's going to need a cardiovascular surgeon, hopefully not, or an oncologist, a cancer doctor, or you name them. But everybody is going to have hormone deficiencies, so everybody is going to benefit from and need for healthy aging hormones to have a healthy second half of their life. So again, I'll go into more details over time. I hope that helps explain some of the fear out there amongst doctors, the unknown, and why there seems to be this problem with doctors talking still negatively to this day about hormones. The hormones I prescribe, I remind my patients, have been in your body your entire life. We're not adding something new. And that should be very comforting to people. Now, is it easy to do? No, it's taken me many years to learn how to do it, to balance it correctly. And the other problem with it, which I think is a good thing, but in a very busy doctor's office, it's not going to work if a doctor's seeing 20 to 30 patients a day, because every hormone treatment has to be individualized and has to be followed up closely with lab tests and adjusted. And I'll end with making that example in one of the more common hormone deficiencies people know of, insulin-dependent diabetes. Imagine if somebody had diabetes because their body was not producing insulin anymore, and a doctor who's unknowledgeable said, oh, you don't need that hormone insulin anymore, just go without it. Of course they don't say that, right? Because that person has a disease, and they learned that in medical school that person needs the hormone insulin. But then imagine that the person does go on insulin, and they say, go on this dose of insulin, I'll see you next year. Because that's what a lot of doctors say about testosterone therapy, estrogen therapy, DHEA, thyroid. Well, that's ridiculous, right? Because the body's going to change, the aging process sets in. The biggest factor affecting hormone levels, in my experience, is stress. So you can't give one dose and say, see you next year. Sometimes they give one dose of a certain hormone, say, I'll see you in 6 weeks. Then I'll see you in 8 weeks. Now, once people get balanced, sure, we can spread out the interval a little bit more. But at the very least, doctors need to interact with these patients 3 or 4 times a year, get a lot of input, and spend a lot of time with them. My first appointment with a new patient is 1.5 to 2 hours. So that's, I guess, the third reason why a lot of doctors don't do this, because they have to jump out of the insurance model into the self-pay model. And a lot aren't very comfortable with that. So I hope this helped explain some of the concerns out there and the misinformation. And in the very near future, I'll be talking more about the difference in more detail about bioidentical hormones versus non-bioidentical hormones. Take care.